Good morning. Over the next 30 minutes to 45 minutes, I'll be speaking to you about assessing cardiometabolic risk in children and adolescents throughout the whole life course, from pregnancy through to young adult life. To orientate you, I come from a team with Professor Wendy Oddie from Perth in Western Australia, as shown there with the red star, from the University of Western Australia and the Telethon Institute for Child Health Research. To orientate you with regards to the structure of the talk, firstly I'll be discussing how we can assess obesity or adiposity in children, and if in fact there is a best way to assess obesity. Secondly, we will be discussing how we can assess the metabolic syndrome, or the cluster of abnormalities associated with the metabolic syndrome in children. Having covered in points 1 and 2 those variables which are universally measured in population studies, we'll then go on to discuss sampling of other cardiovascular tests and markers which have been and could be used in childhood studies. Point 4 is probably the most interesting and exciting part of the talk, and this refers to the applications of the assessment of cardiometabolic risk. In particular, we will look at how we can apply the assessment of cardiometabolic risk to interrogating developmental origin of health and diseases research questions. So, in terms of background, I feel that I need to pay lip service, as is said in many talks, that we are currently in an epidemic of childhood obesity. Prevalences have doubled to tripled in recent decades, both within Europe and as well as in Australia, perhaps with some plateauing in the last decade. Furthermore, to understand the context of why it is so important to accurately assess cardiometabolic risk when investigating DOHAD concepts, we need to have firmly in the front of our minds that cardiovascular risk tracks. Many studies, including those out of the Bogalusa, show that for cardiovascular risk factors including blood pressure, lipids, the metabolic syndrome and obesity, these track consistently from childhood into adult life. This figure illustrates this out of the Bogalusa study. You can see here along the x-axis quintiles of childhood blood pressure measured between 5 and 14 years of age. The highest quintile 5, is associated with an increased prevalence of hypertension in adult life, showing that blood pressure tracks from childhood into adulthood. As a brief revision of DOHAD, or Development Origins of Health and Disease concepts, we know that this field was born out of the original epidemiology performed by David Barker and his colleagues several decades ago, which showed that low birth weight is associated with adult onset diseases including coronary heart disease, diabetes and hypertension. As you can see in the schema marked with the red arrows, it is important to be able to accurately measure cardiometabolic risk at several time points, either as a predictor or an outcome. With time, the concepts of DOHAD have been refined and modified such that it is increasingly understood that it is suboptimal antenatal environment rather than birth weight per se, and its interplay with suboptimal postnatal environment, which together are associated with adult onset diseases, including obesity and the metabolic syndrome. We know that pathways to childhood obesity are likely to be heterogeneous. This intuitively makes a lot of sense, as obesity is a multifactorial disease influenced by lifestyle, genetics, gestational diabetes, other maternal factors, and therefore further in this talk we'll discuss a method by which we have attempted to understand the different pathways to childhood obesity. I've shown this schematically in the green writing, where on the maternal side, factors like environment, genetics, epigenetics, stochastic factors influence this mechanism of early life programming. And on the childhood side, you also have diet, lifestyle, genetics and epigenetics interacting at different time points. The majority of the data which I will present in the course of this talk is from the West Australian cohort study, or the West Australian pregnancy cohort study, otherwise known as the RAINER study. The RAIN study was instigated in 1989 when 2,900 women were recruited prior to 18 weeks gestation. These women gave birth to 2,868 live births, and follow-ups have occurred at 1, 2, 3, 5, 8, 10, 14, 17, 18, 21 and 23 years of age. The current follow-up focuses on obstructive sleep apnea. With regards dietary data, this has included collection of food frequency questionnaires at 14, 17, 20 and 23 years of age, as well as infant feeding and breastfeeding information collected earlier in the study. Biochemistry has been measured at between the ages of 8 and 24 years. Please don't try to read all the writing on this slide, but this gives an indication of the variables which have been collected in the RAIN study. Along the top of the slide you can see the time points, including antenatal assessment, neonatal assessment, and ages 1 through to 23. I draw your eye to the fact that anthropometry, including height, weight, BMI, and skin fold thicknesses, have been measured at every time point, as has blood pressure. DEXA scans and liver ultrasounds were performed at 17 and 21 years of age. Now, moving back to discussing how we can assess obesity or adiposity in children. And I think I'll show you in the next series of slides that perhaps there is, in fact, no best way, and it depends on the question that you're asking. So in terms of cross-sectional measures that are commonly used, they include weight, body mass index, weight for height ratio, waist for hip ratio, skin folds, DEXA, bioimpedance, which measure percentage body fat, as well as different external measures, external standards to look at Z-scores, including those derived from the Centre for Disease Control and Prevention from the United States and the World Health Organization. This slide shows the correlation coefficient between such cross-sectional measures along the right-hand side with intermediate cardiovascular risk factors along the left-hand side. So these intermediate cardiovascular risk factors include HOMA, or homeostasis model of insulin resistance, fasting insulin, fasting triglycerides, and C-reactive protein. The red line represents a correlation coefficient of 0, so in other words, no correlation whatsoever. And the further one is away from the red line, either in a positive direction or a negative direction, the greater the absolute, the greater the correlation. You can see that with the top panel blown up here, that the highest correlation is with waist circumference, body mass index, and waist for height ratio. And in fact, there was no statistical difference in terms of the degree of correlation between these variables. In other words, they were all equally correlated and equally useful as a surrogate measure for HOMA. Similarly for the other measures, insulin, triglycerides and C-reactive protein, the most correlated measures were consistently waist, body mass index and waist for height ratio. This is perhaps somewhat in contrast to the adult literature, which has often emphasised the use of waist for hip ratio, and you can see waist for hip ratio performed universally poorly in this particular analysis in the 14-year-olds. In addition, we are often criticised for using BMI as a measure of adiposity, particularly in adult literature. But you can see here that perhaps in adolescents and prepubertal children, there is not much difference between using BMI or waist for height ratio. This is in comparison to the pattern seen with cholesterol and LDL, where you can see that the shorter children had higher levels of cholesterol, and that height and waist for height ratio were the strongest or most highly correlated anthropometric measures with these particular lipids. And this is, by contrast, another different pattern to that seen with systolic blood pressure and uric acid. And in that case, in these two cases, weight was the strongest correlate. So the take-home message really for this section is that perhaps there is in fact no best measure of anthropometry to use with regard to cardiovascular assessments, and it may depend on the question that one is asking. However, most of our studies are collecting or will be collecting longitudinal measures of adiposity, and I hope to show you that longitudinal models have perhaps more value in the type of research questions we are asking. In the RAIN study, we calculated adiposity Z-scores from 8 time points between birth and 14 years of age using CDC standards. Growth trajectories were then calculated using a technique of semi-parametric mixture modelling. This is a technique which allows one to identify latent patterns of longitudinal development. The optimum trajectory model is shown here. It was decided based upon the Bayesian information criterion.